Hi, my name is Peter. I'm an emergency medicine resident from Denmark, working in Stockholm. And for a while, I wanted to make a new and shorter and sweeter video about airway management. And I got the opportunity now when I just had a education. I just arranged an education week with my colleagues for our residents with the focus on airway. So I had to shorten my airway video down from, I don't know, 12 hours or 16 hours to maybe just half an hour, 1 hour. So this is the short and sweet version. And I think this is much more, as I say, short and sweet, but still retaining a lot of the most important messages. If you want to go into details, then you're free to check out the previous videos and blogs I've done on this topic on airway management. All right, so let's jump right in. References are here for this talk, and yeah, you can check them out if you want. So we talk about basic and advanced airway, and it's really important to stress that in this talk I want to just pull out all of the the pearls from my when I did my rotation in anesthesiology, and from my experience since the last couple of videos. And one of these things, concepts that I really like, is that basic is not the same as easy. When we talk about basic airway and advanced airway, it's not like basic airways is inferior, and it's not like it's easy. If you know your basic airway skills and you know them well, then oftentimes you don't have to know advanced airway. I've made my opinions clear as well about advanced airways management for Scandinavian emergency physicians. And I'll just, in short, say I believe that we should not intubate unless it's a halo situation, which would mean maybe a anaphylactic or asthmatic who has a respiratory arrest right in front of us, where the anesthesiologist cannot come down in 4 minutes or less. There, I think we do have a responsibility. But the reason why this talk is so important nonetheless is that we need to help. Like when you're managing the airway, you need to be a good team member, and you need to go one step ahead, and maybe sometimes give some advice to our airway colleagues about how not to sedate the patient, or how to more optimally manage the patient, and why we should or should not intubate right now. I'm not saying we should own this decision, but we're part of the team, and as part of the team, we need knowledge on how to help and how to give advice to our colleagues in these situations. So this is why the advanced part of this lecture is really important as well. We'll start out by the basic airway part, and I'll just go really short through this. So the basic airway, most of us know it, and I will not go into details about how different methods are carried out. I just wanted to show this from Ruben Strayer, who's done this like kind of sliding scale of the things that you can do in basic airway management. This is from a PSA lecture. And somewhere around here, you will draw a line between basic airway and advanced airway. Sometimes back valve masks are part of the advanced, the basic airway as well. So hand maneuvers, I think the jaw thrust is really good, especially because it can be utilized in also in trauma situations as well. So if you want one way of doing things, I think the jaw thrust is the best one. Maybe not if you have a high risk of if you think the patient has a maxillar fracture or Le Fort fracture, but otherwise, and you do just like the picture, right? You kind of give them an underbite, pull the ramus anterior, And don't put your fingers down here on the soft part of the jaw. All right. Bag belt masks. So just a few tips. I would say that the positioning of the patient is really important. Everything, like when you bag in the patient, you really get a lot of feedback through whether it's hard to bag the patient or it's easy, right? And if it's hard to bag the patient, it could be because they're not relaxed. But if you're not in a situation where you can relax the patient, then the other thing, or the other reason why it might be hard, is because the patient is not positioned in sniffing position. It's not, the airway is not open, and if the airway is not open, then well, it will go into the stomach, and that's bad. So be meticulous in knowing that you have that the patient is in a sniffing position when you're backing them, and that it's easy to back them, right? There are different, like if in the asthmatic patient, there's a caveat there. So in the asthmatic patient, you might not. It may feel like you're backing them gently, and that you don't have resistance, that it's easy to back the patient, but it's probably not. All of the air is going into the stomach at that point, because if you have someone asthmatic, then if you have high pressures in the thorax, they will go into the stomach. And that's why the AMAX4 algorithm will encourage you to intubate instead of using an LMA or BVM if they go into respiratory arrest. The grip. If the patient is easy, then you can use the CE grip, and this you can use by yourself as well. Use your body weight, and it's not a lot of muscle you have to use. And you need to do this a lot to actually, like, you have to practice this a lot in a lot of different phases to become good at it. And you can use adjuncts if you want, but the adjuncts will help you if you're not getting enough air into the patient, or it's hard to back them. Then you can kind of cheat by using the adjuncts, but optimally you probably could have done a better job than by positioning the patient better. But in some situations you do need the adjuncts. If it's hard, then you can use the bimanual and also plus minus adjuncts, right? But you have to be 2 persons to do that. Then the mask. I like the hard masks instead of the soft masks, and I prefer it if it's as small as possible, right? Because then it's easier to get a tight fit. When you distribute the pressure, it doesn't need to have to go hard onto the face, but you need to have an even pressure. That way, you can feel for leakages. So you listen for leakages when you push in air. The bag itself doesn't should not be pushed hard. So you'll push maybe a third of the volume in, or you will check for feedback through end-tidal CO2. You will check if you have that, or you will check it through chest rise. The chest just has to rise. You don't have to overinflate the chest, right? So just chest rise. And in special situations, you may need to do a little bit harder bagging in the beginning, to like kind of get a CPAP kind of effect, but that's only for a few blows. The frequency, you have to get into the rhythm, and I usually use 60 seconds and then divide your wish frequency with that. So if you want maybe a frequency of 10, then you will divide 60 seconds with 10, and then every 6 seconds you need to blow the valve or the bag, right? And when you count it, like 1, and then you push, and 2, 3, 4, 5, 6, and at 6 you need to be ready for the next blow, right? So you need to both have pushed, and it has to be reinflated at that point. So you need to go into the rhythm, and once you have done it for a while, then you get into a rhythm. and then you'll be able to do it within the range. And you can you can try yourself to have a person monitoring you, checking the saturation and checking the entitled CO2 to see if you're doing it in a standard way, and then you can every 5 minutes or so you can check the values and see if you're doing it in a good you're doing it right, and you're keeping that line. That's how your practice become better. And you can do that. You can only do that in the anesthesiology department, right? So, and then it's important to have a underhand grip. So you hold it down here and not up here, even though sometimes there's some kind of a rim up here. You should hold it down here, and you should twist it so the rim is on the downside, not the upside, because then it's more easy to just do gentle backing. It's more like muscle memory kind of, because you're holding up here, then it's easier to just push, right? Also, when you're holding it, you get a lot of information by just both, as we just talked about, when you're blowing it, then you get a lot of information about how hard is it? Should I change the position? Is the patient bronchospastic, and so on and so forth. But you also get, if the patient is still breathing, you do get a lot of information by their inspiration, right? So if you have a tight seal and you think of the patient lying down here and you have the lungs, then you, every time the patient, when we breathe in, when we're not on a ventilator, then it's when we breathe in, the diaphragm will create a negative pressure in your lungs. So that means that there will be negative pressure in the system, and you will feel that by the back will bulge, right? It will blow. It will be pulled in a little bit when they're breathing. And if you keep your hands in a fine motor way on the back, then you can kind of feel when now the bag is moving and it's moving in. Then when it's moving in, then you can blow with the patient, and you can deliver your pressure, your blow at that point. Then you're breathing with the patient. Okay. That's a good way to back the patient when they're hypoventilating, but not totally in respiratory arrest. And you can use a PEEP valve, and a entitled CO2 can also be put in here. That's a benefit. All right. I'll just shortly also mention the other. Moving on to kind of advanced airway, but it's sometimes also mentioned as basic airway, the LMA or the SGA, the supraglottic airway. And where I work, we use these in the operating room, and these usually is pre-hospital, what the patient comes in with, the AirQ and the iGel. Lots of different models exist, and I encourage you to kind of know your own models that you are going to be exposed to, because there's quite a lot of variability in these, especially whether these can be blown up or not, and how stiff they are. But in general, they are used so that you put a little bit of gel here. I think the iGel don't need it, but these AirQ do need it. And then you put a little bit of gel here. And then the idea is that you have to push it in so that this shape goes up to this area of the mouth, right? The soft palate. And then you can just, with the gel here, you can just scoop in. And the main thing that you need to do as a provider is that you need to pull up. You need to do what you call a chin lift. So pull chin up. So what you do is you remove the false teeth. You add gel in the back of it, and make sure that it doesn't come gel in here, because this is what is going on to the airway. So you don't want gel in the airway. Then you have your LMA in your dominant hand, or the SGA, supraglottic airway. LMA is the Swedish larynx mask. And then you do your chin lift with your non-dominant hand, and then you gently but firmly push it into the patient's mouth, maybe with a bit of a direction up onto the palate. And then if it gets stuck, you can just twist maybe 10 or 20 degrees in each direction gently while you're pushing it into the throat. And if in some models it might stick, it might kink so that this tip kinks, and then you'll have to put a finger in here, and then then it will be able to be pushed in there like that. Once you're in, you check for leakage. You can hear the leakage in your operating room. You can see the leakage, but if you can hear leakage, then oftentimes in the ideal model, if it's not a lot of leakage, you can be patient, because there's a kind of a the area here will become moist, and once it becomes moist, then it will kind of suck onto the airway better, and then the leakage would minimize or decrease at least. And that's my experience with the eye gels as well. Though what you can do is that you can reposition the patient. You can try to do a bit more of a chin lift. You might want to move the head to the right side or the left side, which sometimes helps. And then the leakage would become less. And once the leakage is acceptable, then you'll check that the marking is on the right spot. Then you're good to go. And you'll the reason why we want minimal leakage is, of course, well, partly because it can go into the esophagus, but also it can annoy the area. Okay. And if there's a problem, then you can either go up a size or down a size. Okay, moving on to the advanced airway part. So one of the main models, I think, is the best one to learn for the concept of managing airway is this the Vortex model from the Vortex approach. Australians who made this a couple of years ago. So in general, it's just that the concept is this is a funnel, and you have three methods to get air into the patient. You have intubation, you have a SGA, and you have bag valve mask (BVM). You can use once you have what the basic airway management has failed, then you'll use one of these, and which one you use depends on the situation. Sometimes you will have situations where you can't use any of them. Then that's what Richard Levitan would call a surgical inevitable airway, because you will funnel down into the phona right away. But you can use either of these three, and once you can use one optimal attempt at each one before you move to the next one, right? And the idea here is that the entire team knows the plan A, the plan B, and the plan C. It has to be set, and with each failed plan, you'll move one step closer to the phona. And in some iterations of this Vortex model or Vortex approach, you'll say that if you fail one, then you'll mark the neck. If you fail two, then you'll tranquilize the neck and get the phona kit in. And if you fail the third time, then you will cut right away, and you have a person going for the throat right away. So it's a great non-technical tool to be able to get the airway right away. You have one maximal, one optimal attempt at each, but you can try to optimize in between your attempts, and then you have maximally three, and you have something, so you can try to manipulate the airway. You can use adjuncts and so on. And if a senior colleague what they call a wild card comes in, then you can start over within reason, right? If you manage to get one of these, then you go into the green zone, and then you have time to think, time to recover, and time to rethink your move. Different iterations exist. This is from EMCC, the course that I teach. And this one is from SVI, the Swedish anesthesiology society, which is very highly inspired by this as well. Okay, so intubation indications. We've already talked about BVM and LMA or SGA, and now I'll talk about a bit about the rest of the talk is about intubation. I think besides the Vortex model in advanced airway, I think this model is one of the most essential. I don't think it's taught very much, and I only came across it by reading George Kovach's Amy Airway Infinity version book, and that's where that's the source for this. But I like to break this down. So on the y-axis here, you have the indications for intubation. So you have like the highest indication, so it's up here is the highest indication or the most the most acute indication. You need to do it right now, and down here you will have the least one. So the most dire situation is the patient cannot obtain or maintain their airway. They're maybe they have stridor, they're decreasing saturations, and so on. The airway is closing or is already closed. Then you have to do something now. In decreasing severity, then the next one is you have to correct oxygenation or ventilation. The patient is tiring out. The PCO2 is increasing despite your efforts with all other efforts, or the patient cannot maintain oxygenation. Maybe they have SATs of 70 or 60, right? Despite NIV or other devices. Then you have airway protection. If your patient is obtunded or low in GCS and maybe are vomiting or a high risk of vomiting, then the airway protection is important. And then the least acute is the predicted clinical deterioration, like what you call a dynamic airway. And the dynamic airway, of course, can be very dynamic, meaning that it will close within seconds. That's quite rare. Usually you have time, a couple of minutes at least, in the different scenarios. And then there's one indication down here that is not here, but the humanitarian indication I think is important to remember as well. If you have someone with burns everywhere and it's a like disaster of a situation, and you need calm in the room, and the patient for humanitarian reason needs to be calm and pain-free or relaxed, then that's an indication as well. On the x-axis, you have your likelihood of the patient failing intubation, and it's really I really like this because the failed intubation is not only that you don't get the airway; it can also be that the patient arrests because of your attempt at getting the airway. And George Kovach talks about, and first, like Justin Morgenstern and Sarah Krager and everyone else, talks about at least three of these risks of failure. So on the x-axis, I would say that your failure is likely if you have one of these three or several of these three. If you have an anatomical difficult airway, meaning that you have a airway, maybe like you have a patient with no neck, or you have severe burns. The airway is somewhat obstructed. Maybe there's a tongue in the way, meaning that you cannot use normal methods, and so on and so forth, right? So the anatomical difficult airway. Then you have your your psychological difficult airway, meaning that it's usually about non-technical skills. Maybe you have to do it in a way that you have not practiced before. Maybe it's pre-hospital environment where it's dark, where you have to lie on your belly to do it, or it might be a child that you have to intubate. All of these factors might make it less. You'll be more in your stress cone, and you'll be more towards a high stress level, meaning that your motor skills will decrease if you haven't practiced in these kind of situations. If another example is if you're outside of your usual environment, like pre-hospital, right? But also like if you're in the emergency department and you usually intubate in the OR, then that maybe you want, if you can, to go up to the OR or to the intensive care unit to intubate the patient if you can, because you know where everything is there. Okay, those are just some examples. And then the physiological airway, and we'll come back to that. But the physiological difficult airway, in short, is I think one of these things that we really need to know about as emergency physicians, because this is where we can make a difference in these advanced airway situations. So I'll go through that in detail in the next couple of slides. But in short, it's like if the patient is hypotensive or hypoxic and so on, there's a high likelihood when you induce the patient that they will arrest in front of you. So when we look at this map, then you can imagine that if you have a patient who has a predicted clinical deterioration, but there's a high risk of failure, then probably you're in this area where you want to resuscitate before you intubate the patient. But if the patient is over here, right? So maybe it's a patient with pneumonia and that's the only problem going for them. They're not that hypoxic. You can, by pre-oxygenation, get them up to 100%, but their PCO2 is slightly increasing over time. Then you're now in a situation where it's a low risk of failure, but you do need to do something, probably, right? And then, of course, I also want to then you don't have to resuscitate that too much before intubating, right? Then you can do it. It's but I want to also just briefly say that intubation is a bridge, right? It's not usually the solution to the problem. It's just like a BiPAP. Sometimes there's quick reversible things, but oftentimes it's a bridge to something else, right? So you need to be able to actually fix the underlying problem. The intubation doesn't really fix that. Usually it doesn't fix that for you. And that's an important thing to remember, especially as a young physician. Sometimes you call down anesthesia and you think they'll fix the problem, especially in Scandinavia, but they don't. They need you to have a plan, or at least make a plan with them. All right, so this model printed into your memory once you once you're in this situation where we need to intubate. Oh, do we? And is it hard or difficult, or is it dangerous to intubate right now? Do we have time to resuscitate the patient or not? Okay, now moving into the physiological difficult airway in detail, because this is what we really need to know. I think it was Scott Weingart and his FOMET team and colleagues who came up with this concept of hop killers and the series that he had called the laryngoscope as a murder weapon. And you can check that out. I think it has developed a little bit, and now I think the best videos are from Sarah Krager in ICU EDU and First 10 EM. Came out. Justin Morgenstern came out with this video called RSI and Then They Die. Please check those out because they're great. They go through all of these 5 high risk situations where you really need to carefully consider whether you need to intubate the patient now or you can have time to resuscitate them. So we'll go through them one by one. Okay, so if your patient is hypoxic and you want to intubate them, then you need to pre-oxygenate them, of course. And we'll come back to that in a little while, how to do that. But if you have a hard time getting their like giving them giving them oxygen, or if they're so agitated that you don't know whether the agitation is because of hypoxemia, then you need to do something before you intubate them, because once you induce them, even though you may do what you call apneic oxygenation during the induction where they don't breathe, you might have passive or apneic oxygenation. Via nasal prongs, you may do genital bagging with them, but the amount of time that they're not breathing by themselves, that's a high risk time, and that's when they are high risk of desaturation. And if your starting point is around 90, if you look at the dissociation curve for hemoglobin, oxyhemoglobin, then you'll see that around 85, saturation of 85, that's where it becomes steeply going downhill. It goes steeply downhill. So if your starting point is 90, then you're really on the edge already. So you really want to go at least over maybe 96, 98. In an operating circumstance, you want to go above a end-tidal O2 of 80 in Sweden. And sometimes they say 3 to 5 minutes, but what you really want is you want the saturation to be above a certain amount, right? And so what do you do here? Well, you can, if the patient is agitated, then you do a DSI, so that you can do the procedure. And the DSI would be maybe 100 of ketamine to make them calm down. And then you can put on then you can put on oxygen on them, and then you can prepare for intubation or assess whether they need intubation afterwards, because maybe you fix the problem by just giving them oxygen. In other circumstances, if the patient is shunting, meaning that they have a saturation of maybe 70 or 80, and despite your efforts with 15 liters of air on a normal breather, you're not getting the saturation up, then the reason why they're not getting the saturation up is almost always shunting. So to fix shunting, you need to have some kind of pressure, right? You need CPAP or PEEP. So that you can get from optimally you'll get from CPAP or NIV or BiPAP. Just make sure that the patient doesn't have a RV failure or like a big pulmonary embolism, because then once you go from negative pressure ventilation to positive pressure ventilation, either by BiPAP or by intubating them, then the right chamber, your right heart chamber, which is a pressure princess according to Sarah Cracker, is already strained because of the pulmonary embolism, right? And that's why the saturation is low. So if you suddenly change the thoracic pressure to be increased because of the positive pressure ventilation, then there's a high risk of them just going into cardiac arrest. So in those circumstances, you need to thrombolize. But otherwise, you usually can use BiPAP to try to decrease the shunting and then get them up in saturation. I'll go through a little bit of the pre-oxy trial in a little while. So that's what you can do for the hypoxic patient. Then for hypotension, well, if the patient is hypotensive, then you can be sure that the patient will become more hypotensive once you induce them. You have two choices in Scandinavia, kind of. You have propofol or you have ketamine. And propofol is a double whammy. There's a vasodilatory effect in propofol, always, right? So though they will decrease their blood pressure. And usually you would say like a normal, like non-critical ill patient getting ketamine, they will increase their pressure and pulse, right? But not if they're critically ill. If they're critically ill, they're driving on their adrenaline, and any induction agent will remove that adrenaline. So that means that they will fall in pressure, whether it's propofol or adrenaline, so propofol or ketamine. So the important thing is not so much what drug you use here, but it's more the dosage of it. And in general, as a rule of thumb by Scott Weingart, who came in with this idea of propofol assassins. So he would say maybe 25%, maybe 50% of your usual induction dose. So if you usually give 200 propofol, then you should give maybe 25, 50 propofol, and then do it incrementally until you get the effect you want. And be aware that you don't want the full operating theater effect. You cannot get all of the things that you want. They may remember them like once you're intubating them, but as Scott Weingar's former chief said, like, well, thank God that you remember if the patient asks why they didn't do a better job sedating them. Well, thank God you remember, because we thought you were dead. So you would rather remember than being dead at that point. So you will half or quarter your induction dose and give them incrementally, but you will double your muscle relaxant dose, and then you will get pressors and fluids and you on board before doing the induction. You might even pre-medicate them with ephedrine if it's a phenylephrine or ephedrine. If you're using propofol, or maybe just noradrenaline, like getting a drip going. Because then especially if you have a patient who has a brain injury where you don't want to get below a MAP of 80, then you really have to get going, right? Then you're already behind. Okay. Metabolic acidosis. So these are usually the two most common, right? So now we're going into the three less common. Or metabolic acidosis is quite common, but usually you don't have to intubate these patients. And the reason why you don't want to intubate these patients is because they are compensating with their respiratory rate, right? So if they have a metabolic acidosis, they're compensating with their hyperventilation. If you induce them so that they don't breathe anymore, then you really need to hyperventilate them at the same rate. Because if you don't, then they will drop their pH really quickly, and then they will die from that, or be at higher risk of dying. And low pH is bad. Like is a circling. It's a butterfly effect for lots of badness, right? So what we actually want to do, for instance, in the typical case of a DKA patient, a diabetic ketoacidosis patient, you really want to fix the diabetic ketoacidosis. You really don't want to intubate these patients. Again, the intubation is not the goal. It's a bridge to something. And if they can obtain and maintain their airway, if they're not if you can get if they're a bit obtunded and they're maybe increasing their PCO2, or they cannot protect their airway, then yes, maybe you may be forced. They may force your hand, but oftentimes you don't need to. If they're not actively vomiting, then maybe it's better to not do it, right? So, all right. The RV failure patient. We talked a bit about it shortly. You really don't want to intubate the RV failure patient because suddenly the pressure princess, which is the right chamber, if it's acutely strained especially, but also if it's chronically strained, if you have a chronic RV failure, but most commonly it would be in the emergency department would be acute RV failure, then you have a high probability of them going into cardiac arrest. What you will want to do is you want to, like Sarah Craig has done a huge video on this, so check that out. What you can do, but in general you want to decrease the pressure in the lungs and the afterload for the right ventricle. So inhaled inhaled nitro could be a solution. And then you'll, yeah, you can check out the details there. But if it is a pulmonary embolism, then do thrombolysis at that point. And then, yeah, don't do positive pressure if you can avoid it. Then for bronchospasm, we have talked about earlier the management of the anaphylactic or asthmatic patient that goes into cardiac arrest. If they do that, then you will that's a halo. You need to get air into them within 4 minutes. So that's the AMAX4 algorithm. And the problem with asthma is that once you intubated them, you have not fixed them. You've just made the problem worse, because now they have positive pressure and a high risk of air stacking and the high risk of pneumothorax and pulmonary injury and so on. So you really need to treat the asthma aggressively, meaning that you need to give adrenaline, or similar. You need to give the kitchen sink, the magnesiums, your theophyllamine, you might want to use ketamine for both the induction and maybe even before, like a lower dose, and so on. And before going into the intubation, you want to try everything before, like NIV, right? And here's the AMAX4 algorithm again, just to remember. Okay, so I just wanted to hammer home this graph because I think it's so important. So just let's say we have a woman who is found down in the cellar of a burning building, right? She's found on her stomach. She's rescued by the rescue team, and then now she's coming in via ambulance to you. You do your ABCs, where you can see on the A she has blisters in her mouth, in the oropharynx. So she has now a potential dynamic airway. You want to intubate this patient, or probably want to observe her really carefully, but probably intubate her quite within some time frame. But you have time, right? It's not right now, because we want to assess how high is her risk for intubation. So she has SATs of 100. We know that's just fake news because it's 15 liters, and you cannot account, like, carbon monoxide poisoning will make the saturation unrepresentative of what they're actually getting. And we can see on her gas down here that she has a carboxy hemoglobin carbon monoxide poisoning of 26%, right? So she's a high amount of that. So she needs high levels of oxygen, maybe NIV or intubation or hyperbaric oxygen chamber if she has a lot of other problems, or if she has ischemia, or if she has troponin leaks and so on, and or if she's pregnant and so on. All right, so but we also see the blood pressure is low. She has a MAB of 57. That's quite bad. And she has a compensatory probably pulse of 120. On the P, you have an P on an AVPU, so she's obtunded or she's low in GCS, and she has no focal deficits, but she has a head wound, right? And all burn victims are a trauma until proven otherwise. So she might have a hip bleed there. That's bad with the MAP pressure. And she has burns on her entire back because she's been lying on her stomach. On the gas, we also see a potassium of 6, meaning that we don't want to use, if we want to relax her and intubate her, we don't want to use sucks. We want to use rocuronium, right? And also you can see the lactate is high, meaning that when you have a burn victim patient, you want to look at 3 things. You want to look at the lactate. If it's high and unexplained high, and high would be over maybe 8 or 10, then it's a cyanide poisoning until proven otherwise, and you'll give the cyano kit or like the B12. And then you look at the carboxy hemoglobin, and then if that's high, then you'll give oxygen, 100%. And if 50, like if you have NIV, then and she can bear it, NIV. If you have hyperbaric oxygen, then you use that, so on. And the last thing you look at is methemoglobin. Here, I think it's usually above 20. Then you'll get methylene blue. Okay, so where are we? She's somewhere in between here. She might not be able to protect her airway if she's vomiting now. And that's a problem, right? So she's somewhere around here, but where are we on the risk assessment? Well, anatomically, she has a airway. It's still okay. You should be doing her as a trauma case, meaning that she is immobilized, and you can weigh in how much immobilized she should be depending on her risks for hard to intubate and so on. But she probably should be somewhat immobilized. Okay, and so she has a heart and anatomy. You are in a psychological tight space because this is not your usual case, and you have an airway that might be closing soon. And usually, George Kovac would do these awake, but you cannot do this awake, and you probably don't have the time at this point. You might have, but maybe not. But it's really like the physiological airways really where it's high risk here, because you have a low blood pressure. You already need to get the blood pressure up to map over 80 because you have a head wound. You have a metabolic acidosis here as well, so you you really need to make her breathe in the same rate that she's doing right now. And I didn't mention that, but the rate is maybe 20 to 30. Right? So you really need to do that. And she also has hypoxemia. You don't know how hypoxemic she actually is because of that. So really, really difficult patient to manage here. So if we look, if you look at our graph, we're somewhere around here, right? We should resuscitate before intubating. So we might be down here, maybe up here with her. And if she deteriorates, okay, so the plan is if she deteriorates, if she gets stridor, then you're out of luck. Then you need to intubate her now, even though she has high risk of getting neurodeficits if she has a head bleed and so on and so forth. Then you're up here. But hopefully, with the management, we can get her to here, or at least somewhere around here. And maybe she might go more diagonally here, and then it will be acceptable to intubate her, right? So that's the idea. That's the idea of this graph, and I think it's really, really useful. Okay, moving on to the nuts and bolts about intubation. So I presented this checklist, the 6 P's. There are other checklists with 9 P's. I don't care how many P's you use. It's just use some kind of checklist to do these. So plan, position, pre-oxygenation, prepare, paralyze, and post-intubation. So you plan. Planning is what we just did. What is the risk? What is the benefits for doing intubation? What are we going to do? Are there any physiological risks? And what kind of method are we going to use? What's the plan A? What's the plan B? What's the plan C? Okay. And we might use a checklist to go through all of these. Then once you've done that, then you do a positioning of the patient. And the positioning of the patient, depending on how old they are, is different. You want them in sniffing position, but sniffing position in infants is different than sniffing position in adults, right? But in general, the small children, big heads, need towels under their back, and then they'll have a neutral position, and their airway won't kink. The bigger the child is, and usually after a couple of years and going on to around puberty, then they'll just have to tilt the head a little bit back, and then around puberty and onwards, then they will be adults and with adult airways. And usually you need some kind of towel to get into the good position with either a pillow which you push in here, or a towel and several towels so you can push up into the sniffing position, or flextension. So extension of your neck forward here, and then flexion here, right? Okay, so do not intubate in this position. You want to, this I have from Ruben Strayer, you want to get the patient up to the head of the bed and occiput off the bed. That's not always practiced in Scandinavia, but that might be a good way. But then you'll get the head to sternal notch, especially in big patients. You want to ramp them up. so that they have their chest off their thorax. And you cannot stress enough, position is so important with these. Like, there's such a big difference once you go in and intubate the patient. There's such a big difference whether whether you position them better or not. And if you cannot position them in a good way, you really need to consider using like video laryngoscope as your first attempt. And we probably should do that as emergency physicians anyway. But all right. Ears still notch, and you might use towels to because you don't want to hold the head like that. You want to have towels, something to hold the head so that you have this ear still notch. And it's important your position should not be, you don't look into the mouth, but don't get into it. You need to be standing up and get the patient high up, right? Okay, then you do the pre-oxygenation, and the pre-oxygenation I've gone through in another video, so please check that out. But in general, they just came out with last year with a pre-oxy trial, which is a big trial and well done trial. And in general, we probably should do an IV BiPAP for pre-oxygenation in some, if not all, patients. There are caveats to that, and different foam gurus land on different areas of that spectrum. But in general, I think there's consensus that big patients like high BMI patients, and other patients that have shunting, they should get an IV as pre-oxygenation to get their pre-ox up. And then you can use other tricks, and like you can check out the MCRIT, like Scott Weingart's videos on apneic oxygenation, gentle backing, and so on, right? Using PEEP valves and so on. So pre-oxygenation important, and don't proceed unless you actually get it up. Then preparation, and you can prepare in different ways. Here's a dump kit, which is very visual, and I like it. You can also use checklists in different ways, but you need to prepare which stuff you need, right? And there's this algorithm called SoapMe as well you can use. So just have some kind of plan. And what kind of drugs you need? Well, this is from Narkosguiden in Sweden, but in general, you need an induction agent. This would either be propofol or Ketalar. You can use penthol. That's really in special situations. In general, it's ketamine / Ketalar / ketanest or propofol. So these two. If you use the propofol way, then you'll have to use an opioid because it hurts, and there is no pain reduction in opioid. In propofol. So you need to usually fentanyl or rapifene or something like that. And depending on, like, there's different ways to induce the patient with propofol. So if you use a high dose of, and I'm no expert in that, but if you use high dose of propofol, you lose a lower dose of fentanyl. Sometimes you lose a higher dose of fentanyl, and then you use a lower dose of propofol, depending on how painful it is, so on. That's where the anesthesiologists are experts. But just know that the ratio between the propofol and the fentanyl can differ depending on personal preferences and the amount of pain and so on. And these doses are for induction, but that's operation induction, right? RSI is 25% of that, or maybe even 10% of that sometimes, and in incremental doses, right? Okay. If you use the propofol way, so you'll use propofol, you will have some kind of pain agent. You will need some kind of vasopressor, and you can use ephedrine or phenylephrine. Ephedrine will increase your pulse in non-acute patients because it uses your internal adrenaline and activates that. Phenylephrine will decrease your pulse. It will make you more bradycardic, but it works in another way. So it's very much a agent that you use when when they are tachycardic and not so much in the stable patient. In the unstable patient, in the critical ill patient, then the table has turned. You don't use ephedrine as much because they are already spiked out in adrenaline. It won't work as much. That's at least theoretically what I'm told. So you'll use phenylephrine instead there. Or you'll just have noradrenaline going. But these two agents, ephedrine and phenylephrine, works direct on the problem with propofol, which is it vasodilates. And that's also like a bolus question. Like, so if you bolus something and you get more side effects, if you do it slowly and a low dose, then you'll get less of that. Yeah. All right. So then you also, what you also need is, of course, a muscle relaxant, and you can use either Sux or rocuronium. Sux is the short-acting depolarizing, so you will see visually when they're done after 60 to 90 seconds after they're relaxed, and then you'll use that's it. And then it has short half-life as well. There's a long side effects level, like side effect lists, where the most important is hypokalemia and so on. Then you have Esmeron, which is a bit slower. It's not depolarizing, so you won't see when they're relaxed. You'll feel it, and it has a Bridione, which is its antidote, but it doesn't work fast enough in RSI situations to make it a safety net. So it's only used, at least mainly used in the operating theater, Bridione. But Esmeron is safe, and in most situations, if you only need one drug, it's Esmeron, maybe not, and not rocuronium, not the Sux. But lots of discussions about this and lots of opinions. I'll leave you to the internet to figure that out. If you use the ketamine way, then ketamine is inherently also a strong pain relief. So usually you don't need big doses or no doses at all of opioids. You will use a vasopressor, and usually you will use noradrenaline here, probably because because it's not vasodilation that's the problem. Mainly, it's just the general problem with induction agents in the critical ill patients. So noradrenaline is usually the best choice. But if you cannot make it, if you don't have the time, you'll use some kind of push dose, maybe push dose adrenaline. Or you can use one of these push doses, maybe phenylephrine. Okay. You can also induce with rapamycin alone, or some combination of these. And rapamycin or alfentanil is very commonly used as well. Yes. All right. So you have a plan, you have a dose, and you know like what way to do it, and I will just briefly jump to the post-intubation. The post-intubation is really important, especially because there's studies coming out where patient has been relaxed but not induced after intubation, so that they wake up but are paralyzed, and that's horrible. So we need to have a plan after they are induced. What do we do? So, and what drug do they need to get to maintain their intubation or sedation? So you can use a checklist. This is from first 10 EM. Yeah, but anything will do. Then the technique for intubation. So just really quickly, we'll jump back to this step here. So in general, there are different methods of intubation or inducing, there's different methods of inducing the patient, getting them in the position so that you can actually intubate them. So there's a traditional method, which is controlled and in the OR on a stable patient or elective patient. You give them oxygen, then you sedate them, and then usually you give opioid first, and then they say, "Oh, now you will become a bit tired, or you'll get some drinks and wine here, so that you get a bit queasy." And then we say, "Oh, I can feel it." Then you get the propofol. Good night. You can feel it in your arm. It'll be sunshine on your arm, like good and positive thoughts here. And then you'll then once they don't, once they stop breathing, you will get the relaxation agent. Then you'll put it on the clock, wait for 60 to 90 seconds, and while they're not breathing themselves, you'll back them because of a low risk of aspiration. You'll do gentle backing, and you've of course pre-oxygenated them before. And then once you've done that, then you'll do your intubation attempt. Right. So that's the traditional operational method. If it's a high-risk situation for aspiration, that's the traditional reason why we do this. Then you do RSI, because you don't have the time to, like, this takes minutes, right? You don't have minutes, so you need to give everything at once. That's the idea, at least. You get your propofol first, like propofol ketamine with your opioid, with your muscle relaxant, and EM Cases just came out with a quick hit where they talked about giving the muscle relaxant even earlier, so that starts to work maybe 30 seconds before, and then you can start doing it. Yeah, so that's the RSI, and that's usually what we do in the emergency department, because then that's always what we do, if not some of the other ones here. So then you have your DSI, the delayed. That's for the agitation patient, where you want to pre-oxygenate the patient, but you can't, and you think they're hypoxic, so that you'll get them ketamine to relax, or propofol to relax, and then you'll get them oxygenation so that they can accept their oxygenation, and then you can maybe intubate them if they want to. That's the DSI. And then your awake difficult OA. So you'll use awake intubation for especially your anatomical difficult OA, your burn patient that we just discussed, or your epiglottitis patient, or your big tongue patient, angioedema, for instance. But the problem with awake, and you can go to George Kovach's EM Cases sites, or Amy OA, he loves, he seems to be a champion in this area, and he wants everyone to know about it. And I think he has good arguments for it, but it's quite hard to do in an emergency situation. You need to really be good at topicalizing the airway, and then you will do a fiber optic intubation, usually through the nose, and you will talk through the patient, maybe with a bit of propofol before. So the idea is that the patient is awake and breathing by themselves while you are going into the airway, either with an intubation kit or with a fiber optic. And then once the tube has passed the vocal cords, then you say, now induce, and then they induce, and then the anatomical risk is gone, right? Because now you're in the airway. And the indication for this is just that, the difficult anatomical airway, because if you induce them and they lose their airway, then it's a hole in their neck, which is the next step, right? If you use it in the other way, in the traditional way, the RSI way. And that's the reason why awake is something that you could consider in the stable-ish patient who is cooperative, and has a difficult anatomical way. Okay, just a little bit more terminology. You have different plates. You have your Macintosh plate, the C shape, and the Miller, the L shape, or the straight shape. The Macintosh is used for adults, and the Miller is used for children. The Miller is usually, the technique with the Miller is that you kind of, usually with the Mac you go into the vallecula, but here with the Miller you go on the epiglottis to catch the epiglottis so that it doesn't flop down into the airway while you're intubating. You can do that with the Mac as well, but it's not used as commonly depending on the provider. And you have different kinds of, that's what you call DL, or direct laryngoscope. Then you have VL, visual laryngoscope, where you have different brands, and some of the brands is Kaleidoscope, and you also have a CMAC. There's all kinds of. I will mention that, like, the CMAC is just the same as the Macintosh Direct, but with a video. But there is one called a D-plate, and the D-plate is something that we use, which is hyperangulated, and it's instead of going into the patient's right side of the mouth, you'll go just straight ahead with the D-plate, and you need a special guide wire to get the airway in. But once you use the D-plate, it's really easy, and the D-plate is great for airways where you need to like be upside down to intubate the patient, which I've done only on patients that are sitting up for shoulder surgery and so on. So, all right. So then you have fiber optics, and then you have the blind ones. All right. When you want to intubate, it's important to practice this in your mind before and know what kind of steps you need to go through. I can encourage you to do the EVLI or check the EVLI videos out from George Kovac and EM Crit. But in general, I'll refer you to those EVLI videos. And just some quick tips once you're intubating. I've done maybe 60 or 80 intubations now through my rotation, and I'm no expert, but I did get the hang of most of the patients after a while, and some of the tips are quite aligned with what Weingart says in his videos about the Kovac kata, and I've done a video where I go through the steps of a Scandinavian intubation, so you can check that out, but I'll just briefly mention here. Position is so important. You need to get into the sniffing position, both for back valve masking the patient correctly, but also for once you've inducted the patients, they're sleeping. You really need to position them, optimize their position again and again and again, so that you know that once you go into the mouth, it's with the laryngoscope, it's the optimal circumstances for you as you can. So that's important. So you need pillows below under the head and towels and so on. So that's really, really important. I cannot stress it enough. Then you go slowly into the mouth. You don't even have to scissor open the mouth. I stopped doing that. I just pull the head back, and then the mouth will open by itself. And then I, with your left hand, you grip your laryngoscope with a feather grip, not a death grip. So a feather grip all the way down where the L shape or on the curve of the laryngoscope, right? Then you go down there, and then you use it and you go slowly and meticulously in the lateral aspect, like the right side of the mouth of the patient, and then you move slowly, and then you centralize, and you try to look for a friend, right? And you look for the uvula. Once you look for the uvula is going to point towards the vallecula and the epiglottis. So once you found that, then you move slowly, and then you can try to, if you're unused to it and you don't have the feel for it right now, then you can just pull the shaft, pull the laryngoscope in the shaft's direction with force, right? And no tipping motion, so that you don't want to hurt their teeth, but just pull it, and you can see, oh, I'm not quite there yet. Then you move a little bit slower in, and then you can pull up, and then you might be able to see it. We talked about video laryngoscope. The D plate, it needs to go into the middle, but the C plate of the video laryngoscope and the normal direct laryngoscope goes into the right side of the mouth. Yeah, and then if you cannot see anything, this is where Weingart says, you've done all the things and you cannot see anything. It's really important while you're doing this that you're talking with your assistant. So this is a 2-man job or 2-women job or whatever. It's a 2-person job. So you're looking, you're going in, and what you're saying is that I can't see anything, or I can see something. I would encourage you to say 3 things. One or 3 things. I see the whole hole, I see half, or I see nothing. Because then you kind of, okay, if you see the entire thing, then okay, then I'll hand you the tube, right? Then your assistant will hand you the tube. If you only see half, then they'll ask, do we need to optimize anything? Can I give you a push on the neck by manual intubation, right? And or you might need a bushi, right? Or you might need to position the patient better, or something like that, right? And if you don't see anything, then do we need to like think again? Do we need to do we need to ventilate again? Do we need to pull out? Do we need a video laryngoscope? So it's really important to speak with your team while you're doing the intubation, because they don't have eyes in the airway like you do. And they might if you have a video laryngoscope, but even so, you need to talk with them and say what's hard. How can they help? All right. So what Weingart says is, if you're having difficulty, he encouraged you to train this like kata called neck, head, hands, scoop, pullback. So neck is that you will do bimanual intubation, and this is just for the records. It's not a burp, and it's not cricoid pressure. These are two different things, and this is just when you push on the Adam's apple and you try to push the airway into sight. So the patient might be a bit quote unquote anterior. Their anatomy is so that when you go down into the vaguolecula, you only see half, even during optimal circumstances, because the patient is more anterior in their airway. Their airway is more anterior, so you need to push on the airway to get it more posterior into view. Okay, so that's the neck part. So neck, okay, I've done neck. All right, it's not coming into. What can I do? Head is you try to pull the head up with your right hand. So and Weingart encouraged you to do this, like also doing the movements while you're practicing this in your in your mind's eye. So neck, and then head, pull the head up. Hands is like, and the head is like getting into better sniffing position. So if you've done the positioning before, then usually you don't need to. But in hands is you, and that's quite rare. I've never used hands, but the hands is that you take a double hand grip on your laryngoscope, and then you just pull in the shaft's direction with all your strength, or almost all your strength. And then once you achieved max pull, then you usually can just release with one hand, with your right hand, and try again to check out the airway if it's better now. Then scoop. I cannot remember what scoop is. I think it's something. I think it's specifically with video laryngoscopy. Check the video for that. I've never used the scoop, but pull back I have used, and it's usually when you're during your laryngoscopy, like video. I think the last two here are video laryngoscope things. So once you're doing your video laryngoscopy, then you might go in and see what Weingart has coined the Kovac sign. If you have such a good view during your video laryngoscopy that you can see the tracheal rings, then you're too far in, because your bushi or your tube will not be able to fit. Even though you have a great view, you will not be able to fit mechanically because you're too far in. So you need to pull back if you see the Kovac sign. Okay, so that's that. And we talked about communication with your SSK, your sjuksköterska, your nurse or your team member. Might not be a nurse. So it's really important to communicate all the time, both your plans, but also once you go into the airway, communicate what you're doing, what you're seeing. And then you have to practice manually and simulate in your mind what to do once it goes wrong. Practice the kata, and so on. All right. You will see once you go in, you'll see these, like it can be grade 1, 2, 3, or 4. But in general, I will encourage you to say, like, it's much easier to say, I see everything, meaning that you see the entire vocal cord, you see half, or you see nothing. And then that nothing can be like, do you want to try, or there's nothing to try. I can't try anything. That's a grade 4. So I would say here, oh, jag ser, I'm seeing Could I get the tube? Thank you. Here I see half. Could I get a could I get a push on the? Could I get a bimanual, or could I få ett tryck? All right, or position the patient better, or can I get a bushi, please? Here I don't see anything. Try to push, but maybe we want to abort. We could do the same things as in grade 2, but maybe abort. We'll see. You can also, if you have this view, you might want to, maybe you're not positioned good in the valvula. Maybe you want to go just a little bit more in, or maybe a little bit more out, and then pull once more and see if you get a better view. If you get this view, nope, then just pull out. All right, that was the short and sweet version of the airway videos. I hope you enjoyed it, and I'll see you again at another time. Thank you so much, and please check out the other airway videos if you're interested in this fascinating field. Thank you.